At the Vivo Bene Resort in Thailand, these amenities serve a very specific population: Westerners living with advanced dementia. These guests were brought halfway across the world by families who felt they had no other choice. It is a radical solution to a problem that begins thousands of miles away. Back home, many aged care systems are buckling. Standard facilities often struggle with severe understaffing, leaving patients isolated and, in the worst cases, neglected. This MRI scan of a human brain reveals noticeably enlarged ventricles and significant tissue loss. As dementia physically shrinks the brain, it erases the person's memory and their very ability to navigate the world. When the system fails to provide a safe environment for these patients, the entire burden falls on family caregivers. The physical and emotional toll of managing advanced dementia at home, without professional help, eventually becomes unsustainable. Sending a loved one to a resort in Thailand is a desperate attempt to find the level of care and dignity that seems to have vanished from the Western domestic system. Dementia is the physical breakdown of connections between nerve cells. Because those neural pathways are dying and cannot currently be repaired, advanced dementia is recognized as a terminal illness. In terminal cases, the primary goal of care should pivot from curing to comforting. However, standard medical environments often struggle with this shift, defaulting to the same aggressive interventions used in acute emergencies. Surgically inserting a feeding tube directly into the abdomen is one of these defaults. Yet, clinical evidence shows that for someone with advanced dementia, these tubes do not increase survival rates, improve nutrition, or prevent infections. The same logic applies to cardiopulmonary resuscitation. Performing CPR on an end-stage dementia patient often extends biological suffering without the possibility of restoring their quality of life. To manage the agitation that comes with brain failure, many facilities rely on physical or chemical restraints. These antipsychotics frequently backfire, worsening delirium and accelerating the patient's physical decline. Using the tools of intensive medicine on a person whose brain is dying can cause more harm than the disease itself. Neurology and palliative care guidelines call for a different approach. They emphasize person-centered care that prioritizes symptom management and the patient's remaining dignity over invasive procedures. This chart tracks the steep decline in a patient's capacity to make their own decisions as the disease progresses. Because that window of agency shrinks so rapidly, advanced care planning must happen almost immediately after a diagnosis. When a patient becomes agitated or aggressive, an ethical approach treats those behaviors as indicators of unmet needs, like untreated pain, hunger, or simple fear, rather than psychiatric problems to be suppressed with drugs. The model in Thailand successfully eliminates the need for restraints by providing constant human connection and a predictable routine that keeps patients calm. Quality dementia care centers on thoughtful environmental design, high staff-to-guest ratios, and the simple gift of time. Researchers like Professor Bryce Fissel are currently investigating ways to rescue these nerve cell connections. By focusing on rebuilding the brain's internal communication rather than just clearing protein plaques, scientists are hopeful a viable treatment could be ready for human use within 5 to 7 years. While that timeline offers a future cure, millions of families are navigating the terminal stages of the disease today, and they require systemic changes that cannot wait for a lab breakthrough. Moving patients to a tropical resort is a symptom of a broken domestic system, not a scalable solution for an aging global population. Fixing this requires society to rethink